Welcome to Lesson 5 of our DSM-5-TR series. Today, we're exploring one of the most common and widely studied neurodevelopmental disorders, attention deficit hyperactivity disorder, commonly known as ADHD. ADHD is more than just being distracted or hyper. It's a complex condition that affects attention, impulse control, and activity levels, and it can significantly interfere with functioning across many areas of life, from school and work to relationships and daily tasks. ADHD typically begins in childhood, but it often continues into adolescence and adulthood. Some individuals may primarily struggle with attention, while others are more affected by hyperactivity and impulsivity. Many have a combination of both. The DSM-5-TR describes ADHD as a persistent pattern of inattention and/or hyperactivity impulsivity that interferes with functioning or development. Let's go step by step through the diagnostic criteria as defined in the DSM-5-TR. Diagnostic criteria. The first requirement for diagnosing ADHD is the presence of a persistent pattern of inattention and/or hyperactivity impulsivity that interferes with functioning or development. This pattern must include at least 6 symptoms of inattention and/or 6 symptoms of hyperactivity. Impulsivity for children up to age 16. For adolescents age 17 and older and for adults, 5 symptoms are sufficient. Let's begin with inattention. Inattention refers to behaviors that reflect difficulty sustaining focus, organizing tasks, or following through. Symptoms include failing to give close attention to details or making careless mistakes, having difficulty sustaining attention in tasks or play activities, seeming not to listen when spoken to directly, not following through on instructions and failing to finish schoolwork, chores, or duties, having difficulty organizing tasks and activities, avoiding, disliking, or being reluctant to engage in tasks requiring sustained mental effort, losing things necessary for tasks or activities, being easily distracted by extraneous stimuli, being forgetful in daily activities. Next, we have hyperactivity and impulsivity. Hyperactivity refers to excessive movement and difficulty remaining still, while impulsivity refers to hasty actions without forethought. Symptoms include fidgeting with hands or feet or squirming in seat, leaving seat in situations when remaining seated is expected, running or climbing in inappropriate situations, or in adolescents and adults feeling restless, being unable to play or engage in leisure activities quietly, being on the go as if driven by a motor, talking excessively, blurting out answers before a question has been completed, having difficulty waiting one's turn, interrupting or intruding on others. For a diagnosis, several symptoms must have been present before age 12. They must also be present in 2 or more settings. For example, at home, at school, or at work. The symptoms must clearly interfere with or reduce the quality of social, academic, or occupational functioning. Finally, they must not be better explained by another mental disorder such as a mood disorder, anxiety disorder, dissociative disorder, or personality disorder. Presentations of ADHD. The DSM-5-TR describes 3 main presentations of ADHD, based on the symptom pattern over the past 6 months. The first is predominantly inattentive presentation. Individuals with this presentation primarily show symptoms of inattention, but not significant hyperactivity or impulsivity. They may seem to daydream, lose focus easily, or struggle to follow instructions. This presentation is often missed in early childhood because these individuals are not disruptive, but they still experience significant difficulties with learning, organization, and daily functioning. The second is predominantly hyperactive impulsive presentation. Here, symptoms of hyperactivity and impulsivity are most prominent, while inattention is less of an issue. Individuals may fidget constantly, interrupt others, have trouble sitting still, and act without thinking. This presentation is often more visible in early childhood, especially in preschool and early elementary school settings. The third is combined presentation. This is diagnosed when both inattention and hyperactivity impulsivity criteria are met. It is the most common form of ADHD and is often associated with greater impairment. It's important to note that a person's presentation can change over time. For example, a child diagnosed with the combined presentation might show predominantly inattentive symptoms as they grow older. Specifiers. There are also specifiers that provide more details about the condition. The DSM-5-TR includes a specifier for partial remission, which means that full criteria were previously met, but fewer symptoms remain, and they still result in impairment. Severity specifiers, mild, moderate, or severe, describe the level of impact ADHD has on daily life. Mild means few symptoms beyond the diagnostic threshold are present, and there is minor impairment. Moderate indicates symptoms or impairment are between mild and severe. Severe means many symptoms are present, or several symptoms are particularly severe, resulting in significant impairment. Associated features. Supporting diagnosis, ADHD is often accompanied by a range of additional features that are not part of the diagnostic criteria, but are frequently observed. Many individuals with ADHD have reduced frustration tolerance, mood lability, and temper outbursts. They may have difficulty following rules or completing tasks that require sustained mental effort. They might also experience impaired academic or occupational performance, even when their intelligence is average or above average. Social difficulties are common. Children with ADHD may be rejected by peers or have trouble maintaining friendships due to impulsive or disruptive behavior. Adults might struggle with romantic relationships, organization, time management, or maintaining consistent performance at work. Another important feature is executive functioning deficits. These include challenges with planning, organizing, prioritizing, and self-monitoring, skills essential for daily life. Some individuals also display motor coordination difficulties, clumsiness, or delays in motor milestones. Sleep problems are frequent in ADHD. Individuals may have difficulty falling asleep, shorter sleep duration, or restless sleep. Emotional dysregulation, intense, quick shifts in mood, is also common, though it is not a diagnostic criterion. Prevalence ADHD is one of the most common neurodevelopmental disorders. In the general population, the estimated prevalence is around 5% in children and about 2.5% in adults. It is diagnosed more often in males than females, with ratios ranging from about 2 to 1 in children to 1.5 to 1 in adults. However, females are often underdiagnosed, especially those with predominantly inattentive symptoms, which can be more subtle and less disruptive in classroom settings. Development and course. ADHD begins in childhood, with symptoms usually appearing by age 3 to 4, and the disorder is almost always evident by early school age. Hyperactivity is often most visible in preschool years, while inattention becomes more apparent when schoolwork requires sustained focus and organization. As children grow older, hyperactive symptoms often decrease, but difficulties with attention, organization, and impulse control frequently continue into adolescence and adulthood. Although some individuals no longer meet full diagnostic criteria as adults, many continue to experience significant impairment related to ADHD symptoms. Outcomes vary widely. Early diagnosis and treatment, supportive environments, and interventions targeting executive functioning skills can significantly improve long-term functioning. Without support, ADHD can lead to academic failure, difficulties in employment, unstable relationships, and increased risk of accidents and injuries. Risk and prognostic factors. There are several known risk factors for ADHD. Genetic factors play a major role. Heritability estimates are high, ranging from about 70 to 80%, and the condition often runs in families. Environmental factors also contribute. These include low birth weight, prenatal exposure to alcohol, tobacco, or drugs, exposure to environmental toxins like lead, and severe early psychosocial adversity. Temperamental factors such as high activity level, low frustration tolerance, and impulsivity in early childhood are associated with later development of ADHD. Neurological differences have also been observed. including variations in brain regions involved in attention and self-control. Prognosis depends on several factors. Higher severity of symptoms, comorbid conditions, and lack of early intervention are associated with poorer outcomes. Conversely, strong family support, early diagnosis, and effective treatment improve long-term functioning. Culture-related diagnostic issues. Cultural context is important in diagnosing ADHD. Norms about attention, activity level, and acceptable behavior vary between cultures. What is considered hyperactive or impulsive in one culture might be seen as normal in another. Clinicians must be careful not to overdiagnose or underdiagnose based on cultural expectations. It's also important to consider differences in classroom structure, parenting styles, and healthcare access, which can influence how symptoms are expressed and recognized. Sex-related diagnostic issues. ADHD occurs in both males and females, but it is diagnosed more frequently in males. Males are more likely to show hyperactive and impulsive symptoms, which are noticeable early in life. Females often present primarily with inattentive symptoms, which can be misinterpreted as daydreaming or low motivation. Because of this, many girls are diagnosed later, sometimes not until adolescence or adulthood. Suicide risk. Individuals with ADHD are at higher risk for suicidal thoughts and behaviors, particularly when comorbid conditions like depression, anxiety, or substance use disorders are present. Early identification and comprehensive treatment are important in reducing this risk. Functional consequences. ADHD can affect nearly every area of life. In school, children may struggle with academic performance, organization, and completing assignments. In adults, difficulties with time management, planning, and sustaining attention can lead to job instability or underachievement. Relationships may also suffer due to impulsivity or inattentiveness. Driving accidents are more common in individuals with ADHD, particularly in adolescents and young adults. Despite these challenges, with appropriate support and treatment, individuals with ADHD can lead successful, fulfilling lives. Differential diagnosis. Several conditions can resemble ADHD, so careful assessment is essential. Oppositional defiant disorder involves defiant and hostile behavior, but without the pervasive inattention and hyperactivity. Intermittent explosive disorder features impulsive aggression, but lacks the chronic pattern of ADHD. Autism spectrum disorder can include attention difficulties, but it is defined by social communication deficits and restricted, repetitive behaviors. Specific learning disorders may cause academic struggles, but not the broader attention and impulse control difficulties of ADHD. Mood disorders such as bipolar disorder or depression can also mimic ADHD symptoms, but they occur episodically rather than persistently. Anxiety disorders may cause concentration problems, but they are linked to excessive worry rather than distractibility. Substance use disorders, sleep disorders, and even normal variations in temperament should also be considered before diagnosing ADHD. Comorbidity. ADHD frequently co-occurs with other disorders. Oppositional defiant disorder and conduct disorder are common in children and adolescents. Learning disorders and language disorders often co-occur and can complicate the clinical picture. Anxiety and depressive disorders are frequent comorbidities in both children and adults. Substance use disorders are more common in individuals with untreated ADHD, particularly in adolescence and adulthood. Tic disorders and autism spectrum disorder can also co-occur with ADHD. Recognizing and treating these comorbid conditions is crucial for improving outcomes. Summary. In summary, attention deficit hyperactivity disorder is a common neurodevelopmental disorder that begins in childhood and often continues into adulthood. It is characterized by persistent patterns of inattention and/or hyperactivity, impulsivity that interfere with functioning across multiple settings. Diagnosis is based on specific criteria, age of onset, symptom persistence, and impairment. ADHD presents in three main ways: predominantly inattentive, predominantly hyperactive impulsive, and combined presentation. The condition varies in severity and can change over time. It is associated with a range of additional features and comorbidities, and is influenced by genetic, environmental, and temperamental factors. Understanding cultural and sex-related differences is essential for accurate diagnosis. With early intervention, behavioral strategies, educational support, and, when appropriate, medication, individuals with ADHD can thrive and succeed. Thank you for joining Lesson 5 of our DSM-5-TR series. In our next lesson, we will continue exploring neurodevelopmental disorders and build a deeper understanding of mental health conditions.